Good afternoon, sir. Can you hear me?
Good afternoon, Dr. Bharti. You're able to hear?
Yes, sir. I can hear you. I can hear you.
Okay. Good afternoon. Shall we share the screen once?
Yes, sir.
Make up the color. You can see the screen? You're able to see the screen?
Yes, sir. I can see.
Good afternoon, it is there.
Yes, sir. I can see the screen, sir.
Yeah. The slide is clear?
It is clear, sir.
Circle.
Video also.
It's okay?
Yes, sir.
Hmm?
Yes, sir.
What time we should start?
2 o'clock, sir.
2 o'clock, okay. Just I'll go through all the slides. Just check
Sure, sir.
all visibility, all okay?
Yes, sir. It is okay.
Charging now. Animation coming?
Yes, sir.
Good.
Recording in progress.
Can we start, sir, now?
Can we start, Dr. Bharti?
Yes, sir. We can start, sir.
Okay.
So I'll just welcome all the dentists, sir.
Yeah, please.
Give me a minute. I welcome all the dentists gathered here. Let us welcome our guest speaker, Dr. A.V. Ramesh, sir. We are delighted to have you here, sir. So we are looking forward to see have your insights and new perspectives on implants. Welcome you again, sir.
Thank you, Dr. Bharti. At the outset, let me thank Oral G and their initiative to have podcasts or webinars through a Zoom meeting. And it's my pleasure to address upcoming dental surgeons who are looking for how they can go about uh, adapting implants into their day to day practice. Let's start. Good afternoon to everybody.
Sir, give me a minute, sir. Excuse me.
Yeah, please.
Yeah, let me introduce you, sir, about your brief introduction. Let me give a brief introduction about you to all our participants. Sir has completed his BDS and MDS from Government Dental College, Bangalore University. And he has an experience over 27 years as an UG teacher. And as a PG guide, sir worked for 10 years in MR Ambedkar Dental College. He had the positions of head of the department, vice principal, and principal of Oxford Dental College. At present, sir is a professor and guide for certificate course of implantology, which is affiliated to Rajiv Gandhi University of Health Science, Bangalore. And he's having private practice for the period of over 45 years. That is really inspiring to know, sir. Welcome you again. Without much delay, let us start today's session, sir. Over to you.
Thank you. Thank you for the kind introduction. 45 years, if I look back, it appears it's gone in a very quick fashion. So, number of days and number of years when you're into active practice, it only goes like a wishka. Thank you for the introduction. And good afternoon again, and welcome you all for today's Zoom meeting. And remove ಆಗ್ತಿಲ್ಲಮ್ಮ. One second. Okay. I have titled today's topic as implants in practice, a new normal. Why it's a new normal? It's part of evolution of our dental practice that newer things come into place after advancements in science, technology, and clinical skills and evidence. So newer technologies, newer methodologies, newer solution for patient problems do arise. And one such field which has happened in recent time, that is end of the last century and beginning of this century, from past 4 decades, dental implants have come in a very big way to the dental practice. Implants are a new normal because in day to day practice, in day to day clinical requirement, patients do walk in requesting for placing implants in place of their missing teeth. Of course, implants are not a missing tooth. Implant is just a substitute for a natural root which can support a prosthetic, a crown, a partial denture, or a complete denture. So patients' expectations has changed. They are knowledgeable about solution like implant which can replace their teeth is available nowadays. And we also have to adapt implants into our practice because of very good clinical outcome which is based on good evidence and long term predictability. To have a good practice growth and sustainability, we have to incorporate implants into our practice so that the practice which aims for good patient satisfaction will help in this process. And newer things still are going to come. And from initially implants as a support for a lower denture, then implants supporting entire full arch restoration fixed type, then we have advancements in various modalities of implant placement wherein we can meet requirement of every patient. Every missing tooth situation has to be replaced with implant support. So the modifications or adaptations have taken place over these following 4 decades. Lot of improvements and lot of developments have happened in the field of implantology. The question in the mind of beginners, this seems complex. Placing an implant is complex. What if something goes wrong? That may be one question. Do I have enough experience? Because in dental school, it may not be even today. It's quite surprising to note that the authorities or the universities or council or commissions, they have not yet included implant science into regular PDS curriculum or even MDS curriculum. So they're still keeping implants an aside from the regular curriculum. And it's sad to note that only industry is promoting implant science in the clinical practice. So it may be but natural for you to think that you may not have sufficient experience. But I should tell you one important message to you here. Whatever said and done in dental school for graduates, it is only the first step. It's only the door which is open to learn and to practice dentistry into its fullest form or in the most comprehensive form. So it is our intent and our intention which will drive us to acquire new knowledge and new experience and implement it to requirements of the patient. How to learn about it? How to go about learning the science of implantology? When you join dentistry, probably you know that how many teeth a man had or a child had and why people lose teeth. This may have been only the reasons which you would have thought when you joined dentistry. However, in dental school, very methodologically, you have been taught various treatment skills based on normal anatomical structures and based on how a disease progresses and based on evidence how treatment can solve disease. On similar lines, you should also learn implantology, though it is not trained in the dental college formally. How you can go about the suggestions, how you can go about is you should read about implant science in there are many textbooks. If anybody is interested, I can share the details of textbooks maybe with the oral D platform. You can go through step by step theoretical aspect of anatomy which you have to know and the methodology of inserting or placing an implant. Of course, we are talking about the normal root form endosseous implants. Large evidence is available with regard to the protocols, standard protocols of placement, as well as the predictability and the success rate. You can start with simple placement or straightforward cases wherein you have sufficient bone, which I'll explain later how much bone has to be assessed, should be available for placement of implants. And then you can gain your experience gradually so that you can go to more demanding cases. You should have be a part of support network, the large number of clinicians who would like to share their knowledge, who would like to mentor training of implants. And also some universities like Rajiv Gandhi University, they are offering courses in implantology wherein you can have a didactic training as well as one-to-one training for learning implant process. So to summarize, you should go your learning pathway should be phase 1, learn the knowledge or read about all that which is required, the theoretical basis for implantology. Then you should phase 2, you should have some hands-on training. Hands-on training are given on dummy mandibles, dummy maxilla. Then you can also feel natural bone-like material is nowadays available like artificial mandible, and hands-on training can be gained like the drill protocol. Everything can be learned so that you don't feel strange when you're doing in the patient mouth. Third phase is you can have help of some senior colleagues or you can shadow some clinicians who are doing implant practice and can gain first-hand information what could be the problems faced during the treatment procedure. All that can be learnt very easily by shadowing or following some senior mentors who can do the implant procedures. Then slowly, as I told you earlier, go to pick up some straightforward simple cases and start doing the implant placement at your own clinic or at your own hands. By your own self, you can start doing. So that's how the learning pathway can be summarized. So today I would like to touch on basics of dental implants and what are the instruments and material you need to have a dental implant practice incorporated into your practice. Identify ideal or simple beginner cases, and then let us discuss few cases. So this will be the outline which follows now on. First of all, an implant. As you all know, implant is a prosthetic device or alloplastic material implanted into oral tissues that is basically the bone, beneath the mucosa or periosteal tissue, and or within the bone they provide retention and support for a fixed or removable processes. All started with Brennemark in the year 1952 when he started his research on placement of implants. Then he defined what is called as osseointegration. It's a contact established without interposition of a non-bone tissue between normal remodeled bone and an implant, entailing a sustained transfer and distribution of load from the implant to and within the bone. This was put forth by Brennemark, and the results were due to examination under light microscope. Further, group of investigators led by Schroeder and his colleagues called this association of bone and implant as clinical ankylosis of the implant to the bone interface. So we are all familiar with the word ankylosis, wherein a normal natural tooth can get ankylosed to the alveolar bone in the absence of periodontal ligament. So similar relationship is what was explained by Schroeder and his colleagues. Once the implant integrates, we have three tissue interfaces. That is one between the implant and the bone. Then you have the implant collar and the connective tissue, and then adaptation of the marginal mucosal tissue onto the implant. So this we call it as the interface of implant with oral tissues. So now we try to establish not only osseointegration but a total integration of implant with the hard and the soft tissues. Both hard and soft tissues are interrelated in health and disease. Coming to components of an implant has got a fixture, that is the fixture which gets into the bone. Then you have a abutment, a titanium or a zirconia post that connects crown to that of the implant. You have the connecting screw. Then crown, similar to the regular crowns what we do, is cemented to the abutment. The entire complex can be either cemented or screwed into the implant. We need to follow discipline whenever we want to do a clinical procedure. I would like to bring to your notice the tenets of Halsted, which was put forth by William Stewart Halsted, the father of modern day surgery. Always follow this protocol or remember this discipline: gentle handling of tissues, aseptic technique, sharp anatomic dissection of tissues, careful homeostasis using fine non-irritating suture, sorry, careful hemostasis using fine non-irritating suture material in minimal amounts, obliteration of dead space in the wound, that is close approximation of the tissues while suturing, then avoidance of tension. Can you see this here? One second. Along with this the seventh one would be the importance of trauma to the surgical site post-operatively. That is, we should limit the amount of trauma, minimal trauma, and the duration of the procedure should be kept to the minimum. Apart from this, the special requirement as far as implant practice is concerned, when we are doing implant preparation or placement of an implant, impression or placement of crown, precision has to be maintained at maximum level. Maximum level precision gives very good results. Some of the simple armamentarium which I think should not take much time. Regular diagnostic instruments, mouth mirror, probe, tweezer. Then you need incision instruments with the help of BP handle and Bart Parker blades. Number 15 and number 11, number 12 might be most useful. We need to reflect the flap or the soft tissues. We need periosteal elevators. P20 and PBQ may be very helpful. We need curettage instruments to remove unwanted granulation tissue or to remove the tissue tags which may hinder our work, as well as when we are doing like immediate placement where after extraction we may have to do the curette of the socket. So curettage instruments are essential. Then the actual devoted implant drilling protocol, we need a physio dispenser, the osteotomy instruments, and the most recent add-on to this osteotomy instruments is the densa burrs or versa densa burrs. The earlier implant kit, the sequential drills, which are used for minimal traumatic preparation of the bone in presence of a very good physio dispenser which will dispense normal saline in a pulsated manner in a low speed high torque mode. And the densa burrs, usually they do not remove the bone from the osteotomy site. They try to condense the bone chips which are formed due to osteotomy, and they are condensed to the lateral bone itself, so we don't lose bone material in the recent type of densification burrs, or which are also called as densa burrs. Once the placement of implant is over, we need to do flap closure. So good suture material, suture needle, needle forceps, and scissors are required. So these are the additional armamentarium which may be required for which will be required for implant placement. Coming to the patient selection guidelines, like any other dental procedure, surgical, simple dental surgical procedure, like even extraction, we have to follow certain general principle and site specific principles. Presenting complaint and history of the patient. Usually patients will come to you for replacement of missing teeth, or they may be having a bad tooth, either due to bad caries or due to fracture or due to periodontal disease. So the patient is about to lose. So here I should remind you people, like, now the new normal is you should plan a proper replacement for a tooth which you are intending to extract, whatever is the reason you are extracting. But it becomes part and parcel of your planning of the patient treatment, that what will be the replacement. This has to be explained to the patient beforehand, that you are taking a particular tooth out now due to this reason, inevitable reason. But if you are looking for the replacement, these are the solutions are available, number one. And also it is forms our duty to explain loss of tooth without replacement, what are the implications also has to be explained to the patient, and the type of solutions we have, like removable tooth or a fixed tooth or implant supported tooth, all that has to be explained. Medical and social history also becomes very important and essential, because the medical health, general health of the patient is important to determine whether the patient can be given an implant. There are definite relative and absolute contraindications which we have to be very well versed with. Extraoral examination becomes important when aesthetics is of a big concern. Smile line, movement of the lip, position of the lip, all that will become important. Symmetry of the face, everything has to be recorded. Intraoral examination, patient's attitude towards block control and stable periodontal health and dentition like caries free mouth, foci of infection or nidus of infection in the mouth should not be recommended, and good prosthesis. Patient is having a prosthesis, we can assess the patient's attitude towards the prosthesis. Occlusion also has to be studied, which is very much essential because the forces on the implants also play a very big role in predictability of the implant. Investigations which would be required: intraoral radiographs, orthopantomograph, sometimes occlusal radiographs, and nowadays we use digital radiography, both RVG as well as CT scan, medical CT scan, as well as dental CBCTs. These are all investigations which are required to assess the type of bone and the anatomical structures which we have to take care while placing an implant. Preliminary diagnosis and treatment plan. Prosthetically driven means the implant has to support the type of tooth or the type of teeth which have to be replaced depending on the patient requirement and the situation. Patient expectation is another important criteria which has to be considered by the clinician when even thinking or planning to give a implant supported replacement. Site specific principles also, like you have to assess the soft tissue, then you have to assess the periodontal health, the number of teeth present or number of teeth absent, any migration, then presence of earlier processes, and the ridge or the saddle area, the health of the gingival tissue, thickness of the gingival tissue, thin biotype or thick biotype, then very importantly, the bone volume or the height, the inter-arch clearance or the occlusal height. So bone size and the occlusal clearance also has to be literally measured and has to be recorded for planning. Other helpful procedures will be diagnostic wax up and preparation of surgical guides, and of course, nowadays digital planning also will come a long way in helping the clinician. So once the prosthetically driven plan, initial plan is ready, the same thing will be discussed with the patient along with the duration, along with the expected, how much of expectations of the patient will be met, along with the cost. Entire treatment plan should be discussed, and treatment outcome also is explained to the patient. Then the entire treatment process will be started as per the previous plan. A few take home messages when you do the radiographic assessment. As I told you, you can use either intraoral x-ray, which will be very immense help when you're doing single tooth restoration, orthopantomograph when we are planning for single tooth or multiple teeth or the entire mouth, as well as for 3D measurements we have either medical CT or cone beam CT. So these will be useful. Exactly what is the site we need for placing an implant? I should tell you offhand, 7 mm of bone is required, like 7 mm dia of bone is required, and 10 to 11 mm height of the bone is required. That means to say, to place an implant, you need a 7 mm minimum. In that, you can place either 4 or anything above 3 up to 4 dia implants, or if it is more than 8 or 10 then you can place 5 implant. But the guideline which has to be used by the clinician is what we call it as 1 2 3 guidelines. That is, all around the implant there should be a minimum of 1 bone. Between natural tooth and implant there should be 1.5 to 2 and between two implants there should be 3 and surrounding the implant, buccal, lingual, mesial, distal, 1 to 2 minimum is required. There should be 2 space between the nearest anatomic structure. For example, if you're doing mandibular, the posterior area distal to the premolar, then the mandibular canal will come. So there should be 2 between implant and the mandibular canal summit. So before we take up to cases, what I would like to stress, you should become well versed with the basic knowledge which is required to do implant placements in a patient, that is anatomy, physiology, wound healing, drug interactions, then knowledge about local anesthesia. All this basic knowledge is essential. Person who knows, or a dental surgeon, beginners, though they are beginners, the clinicians who know how to do a good extraction, doing a good filling, doing a good denture prosthetic work, they should be able to do with sufficient basic knowledge of anatomy and physiology, as well as the surgical procedure methodology, can do implant practice without much difficulty. So knowledge without practice is useless. Practice without knowledge can be dangerous. So you all have to follow evidence based practice. What is evidence based practice? The easiest comparison which I could give you is, nowadays you use GPS, global positioning system. So from where to where you want to go, you use a GPS, you can easily get navigated and reach your destination. Likewise, evidence based practice, which are available in current literature in various forums, it can be followed, which can give predictable results. So, evidence based practice is conscientious and judicious use of current best evidence in conjunction with clinical expertise and patient values to guide healthcare decisions. Be well learned, then well trained. Coming to the standard of procedures, we have implant placement protocols, which is a little elaborate, but you should know that it will apply, and you can divide your patients who require implant support for prosthesis in various scenarios. One would be, depending on the timing of the implant, immediate implant placement. Dental implants are placed in the tooth socket at the time of tooth extraction. The simple basis for this is that after we extract a tooth, the socket will heal as per the normal healing capacity of the patient. The soft tissue will form, the hard tissue will form. So we place an implant in the socket in such a way that a good primary stability is established and the socket will heal, so that the healing time after placing of the implant and the waiting time is reduced. Sometimes we do what is called as early implant placement. Some indications where dental implants are placed with the soft tissue healing completed. Like after tooth extraction, the soft tissue healing will take place within 4 to 6 weeks. So after 4 to 6 weeks, we can place an implant, but the bone will be still healing. It will not be completely healed. Since we have a good soft tissue coverage and we are sure of establishing primary stability, then we can place an implant, what is called as early implant placement between 4 to 8 weeks after extraction. Late implant placement is what majority of the situations we do. That is, dental implants are placed after complete bone healing at the extraction site. That means in the residual ridge, you are going to place the implant. And as I told you, roughly you need 7 millimeters of residual ridge and 10 millimeters of residual ridge height to place implants. Implant loading, that is, once the implant fixture is placed, we need to load the implant with a artificial crown or a prosthesis. So it can be defined. The loading is when the masticatory load is transferred to the implant fixture through the crown. It is immediate loading. Dental implants are connected to a prosthesis in occlusion within 1 week of placement of implant. So immediate loading is within 1 week. It will be placed in proper occlusion and the patient will be using it for mastication. Immediate restoration, slightly different. Here the restoration is given, say for example aesthetic area, but loading will be postponed till the complete osseointegration take place. So this is called immediate restoration. Dental implants are connected to a prosthesis held out of occlusion with the opposing arch within 1 week subsequent to implant placement. Then we have early loading. Dental implants are connected to prosthesis between 1 week and 2 months after implant placement. Conventional loading. Dental implants are allowed a healing period more than 2 months after implant placement with no connection to the prosthesis. Immediate loading or immediate restoration and conventional loading are the best loading protocol for the beginners. Implant placement and loading protocol can be further classified and divided in as per ITI guidelines, that is International Team of Implantologists. Here I have given you the website of ITI group, that is www.iti.org, wherein you have a very good implant educative interactive platform. Your learning experience of implantology can become very easy. You can enter the website even not being a member and experience the interactive educative platform. And this classification is as per the ITI consciences report. Type 1 is further divided into three categories: type 1A, B, C. Immediate placement plus immediate restoration or loading is type 1A. Immediate placement plus early loading is type 1B. Immediate placement plus conventional loading, that is after 3 months of placement, is called type 1C. All the three are immediate placement. Type 2A, B, C. This is for early placement, that is within 1 to 2 months of extraction. So early placement with soft tissue healing plus immediate restoration or loading is type 2A. Type 2B is early placement with soft tissue healing plus early loading. Type 2C, early placement with soft tissue healing plus conventional loading. So these are the combinations and permutations of placement. Further to this will be type 3 and type 4. So type 4 I would tell here, that is late placement or what we call as conventional placement plus immediate loading, type 4A. Then type 4B is late placement plus early loading. Type 4C, late placement plus conventional loading. Apart from this, we also have one more classification. Again, you all can go through the ITI website wherein the details will be given for type 1, type 2, type 3, type 4, as well as what is called as SCA classification, that is simple straightforward. S stands for simple or straightforward. C for complicated, A for advanced. So SAC classification, simple, advanced, and complicated. So these are the varieties of implant placement and during time as well as ease or complexity of placing implants. Then the prosthesis which goes onto an implant can further be classified as FP1, that is fixed prosthesis, replace only the crown, looks like natural tooth. FP2, fixed prosthesis, replaces the crown and a portion of the root or crown contours appear normal in the occlusal half but is elongated, hyper-contoured in the gingival half. So that means you'll have the crown a little bit of gingival tissue like. Then FP3 is fixed prosthesis, which replaces missing crowns as well as sufficient amount of alveolar bone. So the gingival color and portion of edentulous site prosthesis most often uses denture teeth and acrylic gingiva by but maybe porcelain to metal also. Then you have what is called as RP4, that is removable prosthesis over denture supported completely by implant. Then you have RP5, removable prosthesis over denture supported by both soft tissue and implant. So this is according to the prosthetic classification. This is given by Professor Mish in his bone classifying training keys. Let us get into some cases which I feel you can start with a simple straightforward case. So this case we are going to do FP1, that is fixed processes 1 on an implant support in the region of 4 6 and 4 7, that is first and second right lower molars. As per ITI protocol, this is type 4C, late placement and conventional loading. And as per SAC classification, it is straightforward or simple. Straightforward or simple, wherein you have sufficient bone to place an implant with a simple drill step by step protocol and then closure. So let's examine this adult male patient, 55 years old. The patient complained of missing teeth in both upper and lower right back tooth region, and he wants replacement of the same. Patient underwent extraction of 4/6 and 4/7 about 3 years back. Replacement with implant supported FP1 in relation to 4/6 and 4/6 was a treatment plan and it was discussed with the patient. Here is the intraoral photographs of the patient. You can see right first and second premolar missing and right lower first and second molars are missing. When we when we consider replacing teeth with implants, we usually don't consider replacement of third molars, and sometimes when we do full arch we also consider only 12 units. What, excuse me. So in following slides you will come to see how we are going to replace right first molar and second molar. And here it is missing. We can see that there's good occlusal space also. So this is the orthopantomograph and we have measured this is the crest of the mandibular, edentulous, posterior, right posterior ridge, and this is the mandibular canal. We can see in the area of 6, the mandibular canal is 12 mm away, and near tooth number 7, it is 11.5 mm away. We have evaluated the available bone by measuring on the models as well as measuring the thickness of the mucosa. So in 4-6 region, the buccolingual width with mucosal thickness was 13 mm. In that, we have to deduct the buccal mucosal and lingual mucosal thickness, which combined 4 mm. So we have 9 mm of width. The implant selected because we had 12 mm height, 5 mm by 10 mm. Coming to 4-7, we had 11 millimeter of width, buccolingual width. Thickness of the buccal and lingual mucosa was 4 mm, so we had 7 mm of bone. We selected 5 mm dia because we will have 2 mm all around. Here we'll have 4 mm, and then 11.5, so we selected 8 mm length. So this is how we calculate the available bone for placement of implant. So width of the bone was determined by what is called as bone mapping. We measure the thickness of the mucosa and buccal and on the lingual side with the help of root canal instrument with with a stopper, and then deduct it with the buccolingual width of the bone as measured on the model. So these are the clinical pictures. Here we are giving incision distal to the premolar. This is a crestal incision, and after full thickness flap is reflected both on the buccal and on the lingual side, we can see the table of bone or a good ridge. Here we have placed a small acrylic stent which sits on the neighboring teeth firmly, and we have predetermined where exactly tooth number 6 and tooth number 7 area implants have to be placed. So incision, flap reflection, and surgical stent placement. Then we have carried out the initial drill, which will be of 2 mm dia, and then we have placed two paralleling pins to check the orientation of direction as well as possible parallelism, and we take a check X-ray to see how far it is from the mandibular canal and the height. So 8 mm height has been created here, but the protocol was 10 mm here, 8 mm here. After sequential drilling and in the osteotomy site, both the implants are placed. We can see one or two threads exposed, which can be managed with simple bone grafting. And suture placed. And this is the radiograph of the implant placement soon after they were placed. After 4 months of healing, this is how we open up and connect what are called as healing collars. This will be in the second stage of treatment. The healing collars will be connected, which will left for about 10 days to 14 days. After that, when we remove the healing collar, we can see the implant platform and a very good gingival or mucosal cuff which is formed. This is suitable for going for a prosthesis. In the third stage, we make impression. Here, the procedure adapted is called as fixture level impression with open tray technique using addition silicon impression material. Implant analogs are fixed. Implant analogs are fixed to the implants, and this implant analogs are unscrewed along with the impression, and then we fix what are called as implant analogs to the impression post which has come along with the impression. Then from the lab, we do what is called as a pattern trial to see if there is perfection in our impression making and model making, and it will be cross verified with what is called as a pattern resin trial. Once the approval of patent design trial happens, then we go ahead with making a die and a model and sorry, on the prosthesis like metal trial as well as bisque trial is given, and the final prosthesis is fixed to the implant. So these are called screw and cement retained FP1 crowns. So this is a post fixation radiograph. You can see the good osseointegration, and this is the area where you will have the soft tissue adaptation, and this is the embrasure, and this is where the neighboring tooth is connected. So case 2, here we will be discussing implant support prosthesis FP1 in relation to tooth 1-5, but the protocol is slightly different. It's late placement and conventional loading, type 1C. SAC classification will be advanced. The immediate placement of 48 years female. Patient complains of broken tooth in the upper right back tooth region since 1 month. Patient had undergone root canal treatment in relation to 1-5 about 4 years back. So the treatment plan was extraction of 1-5 and immediate implant placement, replacement with FP1 in relation to 1-5. So this was the broken second premolar. So rest of the teeth are present. So this was the broken endodontically treated tooth, which was not suitable for further restoring. When we took the CBCT, that is the cone beam CT images of that area, you can see the width of the root was 3.9 mm and buccolingual width of the root was 7.7 mm, and length of the root as per the CBCT was 12.5 mm. So in immediate placement, we would like to have primary stability of the implant, keeping slightly palatal to the existing socket and gaining stability in this zone. So measurements I already told you. Length we have 1.5, 15 region. The mesodistal width of the tooth at cement enamel junction was 3.9, buccolingual width 7.7, and the length 12. So we selected an implant dia of 3.75 mm and length of 13 mm. Get slight apical stability. So this was flaps reflected, little more generous reflection of the flap, then extraction of the tooth by minimally invasive procedure, and then placement of the implant more so towards the palatal region. The flap was closed with a little bit of graft, allograft material as well as collagen membrane placed, and sutures were placed. This was the radiographic appearance. Temporization was done with acrylic and wire Maryland bridge. After 3 months, a good healed area, and this is how the implant looked. Second stage was done. The healing abutment was placed, and stage 3, impression post fixed. Here it is fixture level impression, like a simple crown impression, and implant analog fixed in position. This is metal trial, that is on the selected abutment. Trial is given. A radiograph is taken to check the abutment on the platform positioning. And final screw retained FP1 in relation to 1-5. So this is a retained crown. Screw retained crown. So this is 3 months follow up. So this is how it looked. Let's go to one more case. Implant supported FP2 in relation to 2.1 and 2.2. The ITA protocol, it is type 3C, that is early placement, conventional loading 2.1, late placement and conventional loading in relation to 2.2. This was a straightforward case. However, we have utilized digital workflow in this case. 20 years boy. I should tell you people that we don't do implants for less than 18 years of age. We do it in adults. We don't do in children and adolescents, keeping in mind the growth of the jaw. So patient complained of missing tooth in the upper front tooth region and wants fixed replacement for the same. Patient underwent extraction of 2.2 about 1 year back and 2.1 about 3 months back as it was loose. Treatment plan was replacement with implant supported FP3 in relation to 2.1 and 2.2. So these are the intraoral radio photographs. These are the two teeth missing. Rest of the teeth are present. Occlusion, good interarch space is there. This is how the panoramic view appeared. And in CBCT, we can measure the buccolingual width, both 2.1 region and 2.2 region. Though we find it slightly deficient bone here. The digital planning was done to see that the implants are placed where bone is available. This was in the 2.1 region. You can see the simulation of an implant, and this is the safe zone, that is 2 mm around the implant. This is the safe zone around the implant, and this is a guide ring, which will position the implant in the same position. Same way it is done for 2.2. Virtual implant is placed, and this is the position, and this is a ring which can guide us for the drill, and this is the safe zone around the placement of the implant. This is a surgical guide wherein it was developed on a digital workflow, and this is a minimal incision, punch incision, then reflected, osteotomy done, two implants placed in the predetermined position, and temporization done. So advantage of digital workflow is the temporization can be done immediately. So this is after good healing of about 6 months. Stage 3 procedure was done. Like we can see a good mucosal cuff which is formed. Fixture level impression with open tray technique using additional silicone impression. Implant analog fixed to the impression copy here. So this we have tested with the radiograph. So the metal trial, and then we check the metal trial on the model in the patient's implants as well as in the radiograph. The abutments developed. These are the two abutments developed, and these are the PFM crowns. So slight amount of gingiva was replicated in the crown, so it is FP3 implant. So this is the screw opening on the palatal side. So this is the final radiograph after completion. Case 4, last but one case, implant supported mandibular overdenture. Here I should tell the clinicians that mandibular overdenture is as per WHO patient care. Standard patient care for edentulous patients is to provide at least mandibular overdenture supported on 2 implants, which will definitely improve the quality of life for the denture wearer. Here, the ITA protocol which we followed was late placement and conventional loading, that is 4C. And SCSC classification, it was a straightforward situation. 54 years male person working in a bank. His chief complaint was that he was not happy with lower denture, which used to be often felt loose, so uncomfortable. Patient underwent extraction of all remaining teeth 5 months back as they were periodontally compromised or they were mobile. Treatment plan was replacement with two implants supported over denture for the mandibular arch. So these are the patient's maxillary arch and mandibular arch. This was the panoramic view as per the CBCT. We selected two areas to place the implants, that is in the space between canine and lateral on either side. So this was the CBCT images showing the dimension. Uh, Labiolingual thickness 7 mm at the crest, at about 2 mm below it's 9 mm, and then height of 16 mm. So almost similar on the other side, 6.2 mm width at crest and 8 mm 2 mm below, and then 18 mm length. So this was the incision run the intermental foramen area, mid crestal, full thickness. Open the flap on either side. We can see the ridge. In the canine area, we place the implants. This is a PRF membrane which we had kept ready so that it helps in good coverage. Soft tissue coverage will be better with PRF. PRF was placed. After implant was placed, PRF, you can see the PRF here, and closure will happen. This is the implant, complete closure. So in the radiograph, you can see both the implants placed in canine area. This is after 3 months following healing. This is after attachment of what we call as ball end abutments or dolabona attachment, which will give a ball and socket attachment to the denture. So these are the dolabona abutments after good healing, and this becomes the male component of the abutment, and this here you see the female component of the abutment which will go into the denture, and a rubber dam is separating the male and the female component, and cold cure acrylic will be used to carry this stainless steel housing onto the denture base. So this is how it was transferred. Metal encapsulators acrylize into the denture base. So the patient goes happily with upper denture and lower denture also firm in position. Last case, a little elaborate case wherein full arch was covered. ITA protocol type 1C, that is immediate placement with conventional loading, and SSC classification, it becomes a slightly complicated or a complex case. 59 years female, mother of a journalist. Patient has chronic generalized periodontitis with poor prognosis. Treatment plan was replacement with implant supported FP3 in relation to maxillary and mandibular arch, indirect sinus elevation in relation to 1/6 and 2/6. So this was the present patient presented with. You can see periodontally affected teeth, long bridges which are failing. So this was the orthopantomograph. So CBCT comes to good help here. We can measure the bone in all directions and positions and come to the conclusion which implant where it has been placed. Mandibular arch. You can see some areas the bone is less. So this is how the implants were placed in the mandibular arch, full closure with sutures. So you can see a one, two, three extraction sockets and implants. So we can see the other three implants here. Once upper and lower were completed, orthopantomograph was taken, and this showed almost all parallel implants, six in the upper jaw and six in the lower jaw, to support full arch fixed restoration, suturing of the upper arch. Second stage, upper arch and lower arch. This is how the radiographic view with the healing screws and then impression posts. Impression was done, maxillary arch and mandibular arch models were created and processes being fabricated. So this is the, we call it as Polomolo fixture, IO-HPP framework with trial, and this is the radiograph with abutments and processes in position. This is how it appears in the patient mouth. Cement retained FP3 prosthesis. And this is after 1 year follow-up, we can see healthy marginal bone is healthy both in maxilla as well as mandible. This is 4 years follow-up. So to come to the conclusion of today's presentation, the selection of implant placement and restoration or loading protocol should be based on achieving predictable outcomes, a long-term hard and soft tissue stability, optimal aesthetics, reduced risk of complications, meet patient-specific and site-related criteria. Dental implants are best replacement for missing teeth, but they are not natural teeth. Many other advanced procedures like sinus elevation, ridge augmentation, nerve repositioning, zygoma implants, all on four implants, try to meet each patient requirements. Before I conclude, I would like to acknowledge all our patients who came with their requirements and we were able to satisfy meeting their expected results. To all the staff and students of Dental Health Clinic, and to Dr. Mari Abhilasha, who helped in preparing these slides and accumulating all the material available at the center. Thank you, one and all. And I also acknowledge gratefully Oral D, Dr. Vinod, Dr. Netra, Dr. Bharti, and their initiative Nanadara to help learn and grow together. Thank you, one and all. Have a nice day.
Yeah, thank you so much, sir. Thanks for your time and effort and adding value to our participants. Can we take up a few questions, sir, if any of the participants have?
Yeah, please.
Yeah, I would request all the participants, if you have any doubts, please put up here. We would love to take your questions. No questions? I believe you
So
people have really
either
got.
they have okay.
Yes, sir. Yeah, someone is asking, can you go through some light on guided
Yeah, can you read the
guided
question?
surgery pros and cons?
Guided
Guided surgery, pros and cons, sir.
digital guides will help in placing the implants where bone is available, of course, with a prosthetic result in mind. Because the advent of 3D imaging, we can accurately depict the available bone. The cross sections, multiplanar sections of both maxilla and mandibular at the in the residual ridge areas uh, screen on the can be seen on the screen, and clinician can easily measure because they are real time measurements. So the simulation methodology, wherein the 3D simulation can also be done with open-ended software. There are many softwares which can give you implant planning. At one step, upper and lower arch CBCT images are taken, and DICOM files are generated out of the CBCT image, and the clinician should either take upper and lower good impressions, and models will be created, and out of the models STL files will be created. This again a software which creates STL files out of the models, or intraoral scanning can be done. The intraoral scanning STL files or model STL files and the DICOM files of the CBCT images are overlapped, and using 3D simulation software we can place the implant, and we can even simulate the future prosthesis and place the implant as per the required position. Once the implants are placed in the required position in the virtually placed, then a surgical guide will printed out of
Sir, it's frozen. Can you hear me?
clinician will place using what are called as surgical drills. Surgical guide drills are specially available which will get into the digital guide. So in the slots, the digital guide, the drills will precisely go in and prepare the bone. So with the digital workflow, not only proper placement of the implant, precise predictable placement, but also immediate temporization can also be achieved if the temporization is also being done with the digital workflow. Pros and cons: digital workflow is not a replacement for normal surgical freehand placement and management of implants. No, it is not a replacement, but it makes your job easy. And second thing is, like, it all depends on the precision of images as well as precision of impression making or intraoral scanning, and then proper guides also will have a placement guide will be there, a positioning guide will be there, and surgical guide will be there. So the entire complement of digital workflow, if it is used, then the results will be best predicted. So it makes clinician job easier, less time consuming, and more precision can be achieved with digital workflow.
Yes, sir. Can we take up the next question?
Yeah.
Risk involved in placing zygomatic implants, sir.
Zygomatic implants, again the planning is very important. The studying the zygomatic bone present, the available amount of bone present, of course your more skilled person has well as in the cadaver models, and then under mentorship they do it. So a skilled oral maxillofacial surgeon has to place zygoma implants, studying very well the anatomy of zygomatic arch and the nearby vital structures. As you know, it comes close to the orbit. So all that has to be taken care of, and some major arteries also come in the way of anatomically. Plus,
Sir, can you hear me? Can anyone tell me that sir's video is not coming?
in such cases, zygoma helps.
Yeah. Sir, next question is how to decide the charges on the patient, how to decide on charges to patients for implant placement.
Charges has to be based like any other treatment protocols in dentistry. Like supposing you are doing a filling, we calculate the working hours, like working time, the cost of working in a clinic for 1 hour, all the expenditure divided into 1 hour of work in the clinic, plus the cost of the material, plus cost of the lab charges, plus the remuneration for the clinician. So it should be three parts: establishment cost, cost of the armamentarium, then wear and tear, and implant hardware and lab charges. Then one more component is the remuneration for the clinician. So all the three put together. So that's how you have to calculate the cost. So there are very many types of implant systems. By and large, all the systems work good. Some systems have a lot of R&D inputs and very good unbiased scientific evidence, so they'll be little expensive. The implant systems will be slightly expensive. Then you have simulation implants, which the cost will be less. So depending on the system you use, input costs and then output costs can be calculated.
Okay. Thank you, sir. Thank you so much for taking our participants' questions also. I would like to thank all the participants again and A.V. Ramesh sir also. Thanks for your time and effort, sir.
Thanks for giving this opportunity, and I thank all the participants. Hope they are benefited and have some few carry home messages. Thank you, one and all. Bye.
Thank you so much, sir. Thank you all once again.